24-year-old man, 30-minute history, sudden onset, shortness of breath, right side, chest pain, was playing basketball, no recent illnesses or trauma, tall and lanky, 70 kilos, 6'2", decreased breath sounds, hyperresonance, percussion on the right, 94% of room air is oxygen sats, blood pressure 130 on 90, heart rate 80, respiratory rate 18, chest x-ray, visible pleural line with absent lung markings peripheral to the line on the right side, tracheal deviation to the right. He's got a spontaneous pneumothorax, very easy diagnosis here. If they show you the chest x-ray, it's literally as such, where you have a well demarcated line between the lung markings and the empty pleural space. Well, it's filled with air, not fucking lung material is the point. And tall, lanky individuals. All right, so choice A, correct answer, rupture of subapical bleb, which means that up at the apices, you can get some weakening of the alveolar and visceral pleural tissue and get some air trapping up there called blebs, small air collections, and they're structurally weak and they can leak into the pleural space, causing a spontaneous pneumothorax. Something about the taller thorax in certain individuals can lead to greater vertical strain and increased proclivity for the spontaneous pneumothorax. So you're going to get an ipsilateral tracheal deviation here. And USMLE just wants you to know of that mechanism. Just rupture of subapical bleb. I don't really know what to tell you. Okay, there doesn't have to be a specific underlying connective tissue disorder. It can just happen literally spontaneously. So let's just whip through the others. I'll tell you some high points. Choice B, wrong fucking answer. Autoimmune destruction, alveolar capillary interface. Could refer to Goodpasture syndrome. Okay, so type 2 hypersensitivity against the alpha-3 chains of type 4 collagen, male 20s to 40s. And you're going to have hemoptysis, hematuria, linear immunofluorescence, so the type 4, the antibodies against type 4 collagen, aka anti-GBM antibodies, but basement membranes, also in the alveoli. Wrong fucking answer. Choice C, bronchial obstruction and air trapping alveolar rupture. Wrong fucking answer. That could be a secondary pneumothorax. Holy shit. Due to something like COPD. Okay, so you can get air trapping and then rupture of one of the bullae. Like for instance, if you get a chest x-ray in USMLE in a smoker and they tell you there's bolus changes or alpha-1 antitrypsin deficiency, they might say there's bolus changes on a chest x-ray. It's buzzy for emphysema. So you can get rupture of one of the air trapped areas causing a secondary pneumothorax. It's because there's an underlying etiology that's caused it. Whereas with spontaneous pneumothorax, rupture of subapical bleb, it's considered more idiopathic as that being the reason. So let's just whip through the final ones. Granulomatous inflammation, cavitary necrosis, tuberculosis. Okay, so caseating necrosis with cavitary lesions, TB, can also be fungal infections. Barnell-Hensley, cat scratch disease can cause granulomatous. That's caseating. Non-caseating of the lung, obviously sarcoidosis, exceedingly high yield. Borreliosis, made a clip on it the other day, wrong fucking answer. Choice C, reduction of venous return to the right atrium, wrong fucking answer. That's tension pneumothorax. Okay, usually due to trauma, but you're going to have low blood pressure in that setting. Our blood pressure is preserved here. So pneumothorax plus low blood pressure equals tension pneumothorax. So if you have enough air collecting in the pleural space where it compresses, it can compress the underlying lung. It can compress the mediastinum, shifting it to the contralateral side. That's why you get the contralateral tracheal shift. Compresses the vena-cava structures, SVC, IVC, impairs venous return. So the mechanism for low blood pressure and tension pneumothorax is decreased venous return due to compression of the venous structures, the caval structures. You're going to do needle decompression followed by a chest tube for pneumothoraces in general. Very rarely, if a pneumothorax is very small, the patient's stable, well controlled, you can observe. But you're talking virtually every question on NBME. I'm not talking about Qbank bullshit. I'm talking about NBME. You're going to do needle decompression followed by chest tube. Choice C, wrong fucking answer. You know the deal. I'm going to make more content. I'm so scrunching. Appreciate your time. That's it.